So we're going to tell some stories. Will you tell your story?
Oh, absolutely.
All right. There's always more to the story. I'm one of the just over 2% of physicians in the U.S. who are Black women.
I had never met a Black woman who was a doctor.
Actually, I'm the only Black physician in the hospital at this time.
That statistic hasn't really changed much in the last few decades.
People study disparities, but what about interrogating them? What about changing them? What about disrupting them?
I thought about all the time and money it took to get through college and med school and public health school and residency, and how hard it was to pay off all those loans.
People told me that it wasn't enough to be smart, to be a doctor, that you had to work ridiculously hard. All the lore about being a pre-med.
Being a physician, it's just part of you wherever you are. Your first instinct is to help. It doesn't matter if you're in the hospital setting or if you're in the street.
Then I realized the solution wasn't figuring out how to stay forever. The solution was replacing myself.
When Black women tend to step into rooms, we're not just only looking out for Black women. We are looking out to improve the entire environment, the entire system. And I think when we step in to actually open things up for ourselves, we end up opening new possibilities for the whole systems.
It doesn't help to just continuously fill gaps. You have to eliminate gaps.
I have the privilege of being president and CEO of a very respected hospital and healthcare system. Whomever is seeing this can see, yes, this is something I can do, and there's somebody that I can look to that's already done it.
Medicine is a calling. I truly believe that. It's like being a priest, a pastor.
I just find it to be the most satisfying career in the world. There's nothing else that I would want to do.
Everyone has a unique first experience with the medical system here. The seed of each person's career is as different as any two stars in the sky. Bright lights that look the same from a distance can have such very different journeys.
It's who I am. I love the ability to make a difference in someone's life, even if it means one person.
We may be the first, but we certainly don't want to be the last. We have to be able to give back as we move forward.
People like me had never met a Black woman who's a doctor, who is a lawyer, who were all of these things that seem to be possibilities for young men. So I think telling that story and also celebrating that it's so different now is one of the reasons I'm so excited about your project.
Speak into the microphone.
Yeah.
Oh, okay.
I'm supposed to hold it.
All right, fine. Hands off. So I just want to tell you that I'm so excited that you did this. I am going to tell everybody and then shame them if they don't come see it. But I wanted to know, what was your biggest lesson going through this whole process, not just talking to your peers, but just producing something like this to share with everyone? What was your scary moments and your most rewarding moments?
They've all been scary moments. This has been an insanely steep learning curve over the last couple of years. I learned how to be an emergency physician. And so one of the hardest things was believing that I could do something different. The culture of medicine is one that, it breaks you down, it molds you through med school, then it molds you through residency, and it beats it into your head that this is the only thing that you can actually do. Which, in retrospect is clearly not true, because if you're able to do that, you can probably do a couple other things too. But it took a couple of years of convincing myself that I could do something different. And so stepping out of clinical medicine, which is that's the safest thing for me to possibly do, to create this just based on my own experience and feeling the need to have other people who look like me and reflect our communities be in this space. So that was scary and also very, very rewarding. And I think that I knew going in that people's stories would be diverse and varied, and we've also done, I think, 9 or 10 other interviews that are going to be featured in subsequent episodes, but the catharsis that people experienced in sharing the stories, there are more than a few people who have, had tears come up while they were telling their stories, because no one has ever carved out the time to just sit and listen and hold space for them to go through everything that they had experienced. So the interviews are all like an hour and a half long, and we're going to flip them into a podcast down the line so that people can actually get deeper with any given individual. But that has been that was not knowing that that this project would be creating that space for people to work through and process things was incredibly rewarding. And just hearing the stories myself, because when you're one of one or two in a hospital, like I don't have a lot of shoulder to shoulder time with anybody that looks like me. Like I've got great colleagues. I love the teams that I've worked with, but there are different experiences that are not necessarily universal. So.
Here I come.
Hi. In the last 2 or 3 years, I've worked in the health equity space in population health, and what we've seen is an increasing request from payers, so health plans, for race and ethnicity on their providers so that they would be able to publish that information for their patients. So if patients are looking for providers within their network, they would be able to see how these providers identify in terms of race and ethnicity. And I'd like to know your thoughts on that.
Like that is that is such a double-edged sword, right? Like I think it is really important for people to be able to find providers that align with their ethnicity and their background if that would feel safer, because I think that's the case for a lot of folks where, there are plenty of data that show that care and outcomes are often better for patients of color when they have diverse providers. There's more time is spent in the room with a person, more questions are answered, more options are offered. And so that is a lovely thing to be able to do. I'm also concerned about the flip side of that, right? Where people will say, I don't want to see a person who is of that background. And I think it's very complicated. I do think it makes sense to have people know who they're going to see regardless, because then people wouldn't show up to Dr. Cesar's office and say, I'm not going to see a black doctor, and then ask for a hug. One of the things about my work in the emergency department that was really nice was that nobody scheduled a visit. So if it was me, it was me. But that also got me too. Like this patient was wonderful, polite, and congenial in all ways, but one person came in in the middle of the night, so solo coverage, middle of the night, with a shoulder dislocation. And, delayed, just changing so that I could see his shoulder, which you kind of have to do to put it back in place. And at some point, it just sort of clicked. I was like, oh, there's something on his person that he does not want me to see. And I was like, you know what? Look, I don't know what it is. I don't care what it is. Like, my job is to help you get better and get your shoulder back in place. And so we can't do that until you get changed. And so, don't worry about it. And he had probably a 4-inch swastika smack between his shoulder blades. And so, that's not a comfortable experience for me to be in a room with a person who's, clearly placed that on their body for perpetuity. And he was all full of all kinds of apologies, like, I was dumb and young and I didn't. I was like, I don't really care. I just want to fix your shoulder because there's a whole department of people waiting. But, there are flip sides to all of these coins. I do think it's important. One reason I do think it's important, though, is for 5 years that I was at Cooley, I was chief of the emergency department, which means that I read all of the patient complaints and reviews and all that feedback. And I could tell much of the time what the demographic was of the provider and of the patient, sometimes based on the review. And so that was much more about gender than it was about ethnicity, because I was only a black person in the department. But there would be this physician assistant or this doctor was just mean and curt, and I was outside of the room during that conversation. She told you what the options were, but if a male PA or a physician walked into the room and so much as made eye contact, it was just this glowing, patient response. And so I think it's really important that we look at feedback from that perspective as well. And I don't think that has really penetrated through the systems and the powers that be for people who do read patient feedback. But I think it's important because I think we need to start to get all this crap out, like just get it out on the table so we can actually understand the patterns and address them that way, but just to take it all with a grain of salt.
I have a question. It seems like with this first chapter, you are closing a gap. You see the gap. And are there intentions to have this shown at universities for pre-med students to learn? Or high schools, as Linda Pratt just said. Did I misidentify you? I'm sorry. Okay. And that's one question. The second one is, I heard the whole thing that the next chapters are going to be, but specifically, what is chapter 2 going to be about, if you know that already?
Working it out right now.
Okay.
So the first question is, yes, this is the very beginning of our self-distribution of episode 1. So that's another part of this learning curve, like learning how to make a documentary, learning how to fundraise, learning how to like get all the stuff together.
It's incredibly fun.
Thank you, Eeyore. But
I need to use the mic a little.
I have a question for Seth. Seth, how you doing, man?
I'm great.
Okay.
do you want to talk about distribution?
I would, if you don't mind. So one thing that I just want to put this out there, I was talking to Scott about this earlier, is there is a thing that Netflix is the ultimate thing to happen, and it's not. If we did get on Netflix, they would own this movie for 7 years and the algorithm would bury it, right? But we would still have educational distribution rights. So we are going to do streaming eventually, but right now we are working with universities. We're trying to get this into K-12 as well, through 12 as well, because that's who we want to reach, right? So it's not about like, look at us. It's like, no, let's go to who needs to see this. So we're setting up distribution through an organization, community screenings through an organization called Khama, which does all the technical aspects for us so that we don't have to
scale.
do it. Yeah.
We can scale it instead of, because
Yeah.
really it's like the two of us making a lot of phone calls and sending a lot of emails and doing all the yada yada. So
Yeah.
when we're able to do that.
So but distribution is very, very difficult. We had like no idea. And we were talking to educational distributors about it and finding out that they wanted 70% of the take. So we're doing it ourselves because that's ridiculous.
So, but the Khama platform will allow us to scale and make it more widely available with less of our time to make it happen. And for episode 2, it's semi-generational, and so these are sort of clearly trailblazers in their own ways. The next episode is going to be folks who are both primary care physicians and emergency physicians, so sort of frontline folks. And some of the themes that are coming up are really just resilience. So either people who, because I think one of the things that, one of the myths that people have if they think about going into medicine is that they have to have gotten an A in absolutely everything throughout their lives and can never have had a hard time with anything. And so there's one doc who experienced homelessness. There's another doc who had to take two buses and a train to get to her MCAT prep course because she lived in a really sketchy area that had nothing available. There's a couple of folks who took the MCAT a couple of times. And so just really trying to break down some of those myths and loosen up the hierarchy so that people can actually see that this is attainable.
Oh, but 4 episodes in all that we're working on.
Yeah.
So 3 more full-length films that we're going to be doing.
Part of it is also because I want to show the diversity that exists among us, and also which includes geographic diversity. So episode 2 includes docs who are in Alabama, Washington State, California, and Massachusetts. And the 3rd and 4th episode will feature docs who are in the Mid-Atlantic area and also the Midwest, because I don't want a kid in Wisconsin to say like, yeah, that's great, but that's a coastal story. That has nothing to do with me here in Minnesota. Like, yes, it does, and she's right there. So this is also your story too. And also showing different specialties, because I didn't know that there was anything beyond internal medicine, pediatrics, and obstetrics when I started med school, honestly. Like I had friends who came in knowing that they wanted to be a cardiologist, and I was like, you could do that? Like I was that clueless. Like I did not know what I was doing. I knew that I wanted to be a doctor, but I did not really have a full grasp of what it meant. So I want to open those doors as well, so people know that like there's a surgical oncology is a thing, and psychiatry is a thing too that is provided by Black psychiatrists, because mental health is important, especially in the Black community where there's a lot of stigma about it. So really wanting to just bust it all open, just big red button. That's my goal.
I was just going to ask about the distribution. You had you, and your colleagues. I mean, they represent, I'll just talk loud. They represent some of the biggest universities in the country, well recognized, both from undergrad and graduate school, and also your residency and fellowships. And I would think that, I'm just thinking of Brown. We went to Brown. So, their alumni association loves this stuff. They eat it up. This is the kind of stuff where any one of those universities would be like, wow, here's one of our guys. I would think. So, as far as the distribution, this is a highlighted thing which could, maybe wouldn't have to be taking 70% of the take.
Yeah. Totally. And that's what we're doing. So there's basically all of these concentric circles that we're looking at where there's overlaps, and it's basically you need a champion, either through the Alumni Association, through a department, we have a PhD student at UMass who's just like knocking on every single door to make this happen. So we talked with Smith, an 11-minute phone call there, we were done. We had a screening, but UMass is gonna take months. And it's just like how it is, but we would love to talk to your Alumni Association.
And I think exactly, and we'll do these screenings, we'll get some quotes from folks. This is really like, y'all are in the early side of this. We're just getting started with getting this out there. We completed the episode in October and had our first screening funded by Mass Humanities, and then these are the first ones that we've had since then. And so working on putting it all together and just gonna hoof it and get it out until then.
I'm just curious as to the people that you've interviewed or people that you may have known, and have they went into the medical field, done that for years, and left and did something else?
So what's kind of funny is that when I started this, I was leaving. Like I was done. I was done with emergency medicine. I was done with clinical medicine. And so I also felt that's part of why, somebody asked about like, when am I gonna be in it? That's part of why I wasn't in it that much, is because I felt like, how can I really like bring people into this space that I'm trying to bounce out of? And in hearing these stories and having some time to just sort of recover myself from my couple, from a lot of what I'd been doing before that, like I sort of refound my love of clinical medicine, and I really like working with patients, and I like solving these puzzles, and I just had to figure out a way to do it that was also healthy for me to do it. And so that's what I've been able to do in the last year, not quite year. And so I think that for me, it looks like integrative medicine and holistic care. So we're sort of bridging the gap of like, I'm an allopathically trained physician. I think it's a wonderful set of offerings that assumes a lot about how we are doing that is not true anymore. Like our food environments are trash, right? Like there's so much that is not healthy about the spaces that we live in, our sleep patterns, our ability to move our bodies safely. And until we fix that, you can come up with whatever new wonder drug and they're all great. And if it's the right thing, it's the right thing. I'm not gonna be one of those like, don't take your blood pressure medication, docs. That's not good. But if you wanna reverse your diabetes with food, so keep taking your meds until we figure out a way to do it metabolically. And then if you can get that caught up, then you can ditch the pills. So that's the headspace that I'm in clinically at this point, which unfortunately does not fit within the larger structures of medicine because that requires time and conversation with patients, but it's what I'm doing and it just feels better. So there's one doc, I think, who left clinical practice altogether, and she'll be in the next episode. She does more utilization review. And then there's another one who'll be in the next episode who learned at some point that full-time clinical practice was not a sustainable thing for her. And so she figured out how to bridge the gap between that and admin work. And so I think we just need to see different ways that this can look.
Hello. Thank you so much for putting this together. I think that it's extremely important. I am currently a fourth-year psychiatry resident at UMass.
I didn't even know that when I said that before, by the way. You were like, I promise she's not a plant.
Right. And I think that I wish I had seen something like this before, kind of before starting this pathway of kind of being the first person in my family to be a doctor and really having to figure things out along the way at each step. And so I definitely empathize with you guys trying to figure out how to do the filming and everything, like, and distribution and all of that. Because sometimes it feels really hard and kind of like a lonely feeling of, you know, like I wish I did have someone that I could look up to that was close by. I also had that similar experience of meeting my first Black female physician like while in med school, but since being in residency, I haven't seen any, and it's really just been me, and then just trying to balance that with kind of being the leader in my program, but also like wanting to sometimes take a step back from clinical practice. And it's something that I thought about kind of early on since I'm not even done. But like feeling like I have to be there clinically because I know that we're unicorns. So then there's also that kind of push and pull of like, at what point do I take care of myself? And then at what point am I like there to be helpful for other people? And with psychiatry, the stigma is strong, and it's also hard that a lot of the patients I take care of don't look like me. And the few times I do see them, then it's, you know, like, oh my gosh, I'm so happy to see you. That it's their response to me. But like, it's hard to not do the thing that I feel like I'm here to do, which is kind of be that representation. So it's just kind of this weird cycle. So it's not quite a question, but
I get it though.
Yeah.
Like I get it, and I see you. And if I could give you just like one tip that I learned 15 years later, like you can't. I loved a lot of what I did, and I ran myself into the ground, and I wasn't going to be useful for anybody anymore if I didn't pull myself out when I did. Like I didn't get chased out. I was doing great. People were like, oh yeah, come on, it's great, it's great. So happy for you. But but it was not sustainable for me. And so I think if you can hear that voice that's saying like, maybe not full time, maybe balance this with something else, do that now. You don't have to. Like this is not, you didn't create this. It's not your job to fix it. It's your job to do what you can to be around for who you can take care of. You don't own this. If you want to, more power to you. But if you don't, you don't have to.
Unless there are other questions, thank you to. Oh, sorry.
Thank you.
And get my number before you leave.
So I want to say thank you because you all reached out to the Holyoke Public Schools and provided us with tickets for our youth to come. And we had one youth who attended this evening. I had to bring him back home, but he was here. He was like, make sure you tell them I was there. I was like, okay, I got you, Zeke. And so the reason why we really wanted to come is because I oversee the ethnic studies program, and we're always looking for ways to like engage our students in being critical around the world around them. And part of that is expanding our curriculum to engage them in like new ways of thinking about what are the possibilities for them in the world, especially our brown and Black students. And so I've been recently we had a physician, a Black female physician actually, visit and sit in on one of our professional development days. She reached out and was interested and was looking for a way to partner. And then this happened, and I was like, yo, how do we make this happen? And so I'm wondering, after all of that long explanation, have you had an opportunity to bring this into K-12 spaces? And if not, are you open to a thought partner?
Yes. Well, no to the first one, yes to the second one. So yeah, let's definitely continue that conversation.
Yeah, we're working on that. That's part of the educational distribution aspect. But like,
will you be our guinea pig?
We're doing it. Yes. We are now doing this.
Okay. All right.
Hi. Hello. So she
I
said
have no shame.
So she said you reached out to the Holyoke Public Schools. Did you reach out to the Springfield Public Schools?
I didn't.
All right, so I'm the Springfield Public Schools.
So
okay. All right.
You can thumb wrestle about who gets us first.
Listen. So let me tell you. So in the next couple of months, June, probably May or June-ish, we're gonna sit down and talk about the budget, and I want to figure out how we can get you guys in there.
Yeah. We'll make it happen.
And another thing is we price things so that it can work, and we want people to see it. So we can figure that out. If there's a university and we know they can pay what we are asking, they can pay what we're asking. But if you need, we can figure that out. We want people to see this.
In case you don't already know, like a fun way to get funded for things like this, or how it's worked for me in the past, is like we build, there's every 5 college has like community-based learning opportunities. And so they will sponsor, right, because they have the budget to sponsor folks like you all to get the money that you need and deserve for your work and labor. And then they will sponsor one community event, and so I'll host it at one of the schools here, right? So we bridge the work, and so y'all can get the coins and we can get access.
Let's do it.
Does anybody else have a comment or a question? I want to thank all of you, each and one of you, for coming tonight, and Seth and Khama for doing this hard work. We at Holyoke Media know exactly how hard it is to do what you did. And it may look, it looks beautiful and easy, and it's so, you can get in a bad mood about it sometimes. So thank you very much. I'm glad you're making some connections here, and we hope to keep supporting you, the chapter, episode by episode. Thank you. Thank you all. Eat the food. Take food home.
Ooh, and have some more food.